Friends, this eye has asteroid hyalosis with a brown cataract. I've taken up this case for surgery. Let us watch the surgical steps. The patient is under topical anesthesia. The patient is moving his eye a lot. Patient is not able to cooperate well, but I could manage the case very well. By this time, the main incision and on side port on the left side of the main incision has been made. Now I am going to stain the anterior capsule of this cataractous lens with trypan blue dye, and here is the dye. After injecting the dye underneath an air bubble, I wait for very little time, about 5-6 seconds, then I wash the dye out of the anterior chamber. And now is the time to fill up the anterior chamber with viscoelastic substance, and this is hydroxypropyl methyl cellulose 2%. Now one more side port is made on the right side of the main incision. The patient is very uncooperative and I am not able to keep centration to show you the surgery well, but still you will be able to understand many steps of this surgery. This is a side port on the right side, and now I'm going to do capsulorhexis. The capsule is incised with a 26 case bent needle and a capsular tag is raised. Now I use a utreta forceps. I go into the antechamber. Here I am fixing the eye with a fixation forceps because the patient is moving his eye a lot. So I fix the eye with a fixation forceps. Then I am using the utreta forceps, holding the tag, going anti-clockwise. I am at a certain distance from the margin of the pupil. I try to remain at equal distance all around from the margin of the dilated pupil, and thus I get a fairly round, adequate sized rhexis. Here the rhexis tended to be small when I came at around 2 o'clock, and then I went a little peripherally and the rhexis has taken a pear shape. And now is the time to do hydro dissection. I am using balanced salt solution and 27 gauge cannula. And little bit of fluid is injected under the air bubble. The fluid goes to the opposite side, and thus I could do hydrodissection. The nucleus is tapped, the nucleus is rotated. Viscoelastic substance is injected again, the antechamber is filled up, and now is the time to introduce the tip of the phaco handpiece. The machine being used is Oatley Cataract 3 phaco machine. A beautiful machine. This is a 2.8 millimeter incision. See, the tip is wider. The end of this phaco titanium tip is wider. The shaft of the tip is narrow, and thus the wound is always free, and enough fluid is there all around the shaft, and thus wound burn is almost nil in this case. Here I am doing direct chop. I am burying the tip into the substance of the nucleus, holding the nucleus very firmly and chopping it. I'm sorry that the centration is not good. However, I am taking care of that. In a short while I'll bring it to the center. Here the phaco power being used is here. The centration is okay. Now the phaco power being used is about 70%. Flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. And now this is the emulsification of pieces. It is going very smoothly. I'm in continuous mode. I apply energy only when nuclear material is there, only when the nuclear material is in front of the tip, occluding the tip. Epinucleus has also been removed, and now I am very cautious. See, in this case, there is asteroid hyalosis and lot of crystals are there, and the reflections from those crystals are causing some hindrance in viewing the posterior capsule. Yes, the posterior capsule is getting lot of reflections from the crystals, and I'm having some problem in seeing the posterior capsule. So I'm very cautious. I don't want to polish the posterior capsule in this case. I just want to remove the cortex. I'm holding the cortex from the anterior portion of the cortical matter. I mean the part of the cortex which is just on the undersurface of the anterior capsular rim. I just hold that and pull it towards the center and then remove it. Many colleagues ask why the side port is so large. See, the side ports are 3 clock hours away from the main incision. The main incision is 2.8 millimeters. These side ports, since they are about 3 clock hours away from the main incision, yes, exactly 3 clock hours away from the main incision, so the astigmatism produced by the main incision will be corrected to some extent by these side port incisions. In this case, I'm going to use a B cartridge and sensor single piece intraocular lens. I don't want to use irrigation in this case for implant because I can't see the posterior capsule properly. So I have filled up the capsular bag with viscoelastic substance, and now I'm implanting the lens in the capsular bag. Since the anterior capsular rim is stained, I could see where the lens is going. Yes, it has gone into the capsular bag. Dear colleagues, situations will not be in our favor in many cases. Like in this case, the crystals of asteroid hyalosis are causing some hindrance in viewing the posterior capsule, and we have to do it in a safe manner. So in this case, I didn't implant the lens under irrigation. I used viscoelastic substance. Viscoelastic substance protects the posterior capsule better. So if you want to implant the intraocular lens under irrigation, be very confident and be very confident of your gentle movements. Be very confident of your hand movements. Since we have used viscoelastic substance in this case, it has to be thoroughly removed. I am using bimanual irrigation aspiration in this case to remove the viscoelastic substance. And before that, I have used Simcoe and irrigating probe to flush out the viscoelastic substance as much as possible. This is very important to reduce the intraocular pressure in the postoperative period. And see the number of crystals. Thousands of crystals are there in this case. The side ports have been hydrated. The side ports have been made waterproof. And now is the final lavage of the anterior chamber. This is very important. The final lavage of the anterior chamber with pure BSS keeps the anterior chamber very quiet, and intraocular pressure remains normal postoperatively, and you get very satisfactory postoperative result. Thank you very much for watching. Hope this video will help you in developing your surgical skills.